Good morning, professors and doctors. Our case today from the endoscopy unit of the Armed Forces College of Medicine Teaching Hospital is a 42-year-old male patient with a history of liver cirrhosis and portal hypertension secondary to chronic hepatitis B, which is well controlled with entecavir. The patient has history of repeated upper endoscopies and esophageal varices band ligations. Last endoscopy 3 weeks ago revealed esophageal varices grade 1 and a large isolated fundal varix. So, the patient was referred to us for EUS guided fundal varix injection, which will done today by Dr.Amr Abul-Magd, lecturer of gastroenterology and hepatology, Armed Forces College of Medicine.
First of all, I want to thank all Egyptian Society of Digestive Endoscopy team for this wonderful meeting. Do you hear me?
Yes, it's very clear. Dr. Amr, you can hear and see the screen for the EUS and the endoscopic screen also.
Yes, as we heard, we have here isolated large fundal varix for chronic hepatitis B patient. We are trying to do intervention EUS guided intervention of this large isolated varix. Of course, we have also that EUS is more safer than conventional injection, because if the field got messy or there is bleeding post injection, you can visualize through the ultrasound image the varix and continue injection despite the bloodiness of the field. Do you agree with me? Of course, as you know, that is air is the enemy of the echo ultrasound. But if even bleeding, it may be hard to us for complete ovalization of this fundal varix. Second important thing, you have to inject water to see the submucosal varix. That is what is going to direct management. Inject
Okay.
water, please.
So you are injecting water to...
So now, Dr. Amr, you are injecting water, if we can see clearly, yeah? You are injecting water?
Yes, we are injecting water to identify the submucosal varix and
Yeah.
identify the inflow of the varix to inject in it. So it's very important to identify the inflow for proper injection and complete obliteration of the varix.
How to identify the inflow and outflow? Dr. Nada,
Yes.
the fundal is a complex system. You have to recognize three important things. The first is the inflow, and the inflow is appeared by color Doppler is red because the flow is toward the probe, and the outflow is appear blue because it's away to the probe, to the portal or systemic circulation. يبقى red toward my probe is the inflow, and blue is away from the probe toward the systemic circulation. This is the first important method to detection the inflow and outflow. Second is,
Applying color Doppler.
yes, the inflow is positive wave,
Like this.
and the outflow is a negative wave.
Yeah.
This is the best two method to identify the inflow, which is going to the big fundal varix, and the outflow is the way to have to avoid, because injection into this systemic outflow is go to
Distant embolization.
distant immobilization. So you have to identify the inflow and the outflow, and mostly the inflow is near the splenic hilum, and this is the spleen here, and this is the splenic hilum, and this is the inflow, and here is outflow. So if I want to target, I will target this inflow, because this inflow, if I follow, it will go to this large varix. But I need more water.
I think you need to add more water, inject more water, Dr. Amr.
Yes, I
Yeah.
will do.
More.
Here, this the submucosal varix. Dr. Gasser will show us as water كمان. Dr. Nada, do you see this submucosal varix?
Yes, yes, it's clear.
So this is the first layer, is the artifact of mucosal surface. Second is muscularis mucosa, and you can clearly see this varix is located at submucosa.
That's the hyperechoic area or layer.
So
This hyperechoic layer. Yes.
always, the fundal varix is located at submucosal stem. And here you can see this perforator is passing through the muscle layer to the splenic hilum. So I have two options now. If I want to target submucosal varix or targeting the inflow, and it will be just injection of 1 ampoule of cyanoacrylate. What do you think? And I need to see your comment.
Hello, Doctor. I am Dr. Ibrahim Mustafa.
أهلا Dr. Ibrahim.
How are you? Fine?
I am fine.
When you speak about outflow and inflow, it is, I inject from the versus since 34 years now or more. We don't have EUS, but we inject from the versus as it is. We inject and we have in all these years maybe 1 embolizations. So maybe the EUS may be very good if you inject the perforator, because I think my experience, which was many publications, not only my experience, that we don't have very high incidence, only 1 case in 30 years of distal embolizations. So my opinion that the importance of EUS is to inject the feeding vessel, not the vein itself. So what's your opinion on that? Because the vein itself we injected, we don't have inflow and outflow. We inject the fundal, but we inject it slowly. It's dependent upon how to inject. You inject it slowly, don't inject very rapidly. You have with lividol, and you inject a big amount. So by this means, we don't have a complication in the 30 years. So my question to you will inject the feeding vessel or the fundal itself?
But I told you, Dr. Ibrahim, I think I want to thank you for this good point of view. The first, the perforator, at most of time, it's not easy to detect. The second important thing that the perforator is passing through the muscle layer. So it may be such as much complicated rather than injecting the feeder, because it may be cause necrosis at the muscle layer. And injecting through the in feeder injection, it's much more safer. The cost is less than adding coiling to this large varix. And of course, I am not direct puncturing this isolated fundal varix. I inject in another area at the splenic hilum. I don't inject direct to this large isolated fundal varix. So feeder have more than benefit rather than injected this large isolated fundal varix. But
so you injected the vein itself, or you injected the feeding vessel?
I injected the feeding vessel here. This is the inflow.
So you injected the feeding vessel?
Yes, here this is the feeding vessel.
This is my question. So you injected the feeding vessel, which gives the blood to the fundal varix. This may be
completely right. And it's red in color.
I know, I understand.
Yes. But
you don't inject the vein itself.
No, I don't inject.
Sorry for interruption, Dr. Amr.
And acrylate. I starting now putting my needle at the inflow, and I flush with water. Now I inject cyanoacrylate and injecting, keep flushing, and I now obliterated at all the inflow. putting tunnel Doppler.
ماشي بس عايز بس انشور عشان انا بس حابب بس ده عشان استنت بس البيانات.
I think we can mute the sound in the room Ain Shams University, please. And we are with you, Dr. Amr Abul-Magd. Yeah, we are hearing you.
لا هو اصلا الواير ده طالع فيها. طيب اوكي هنبص احنا كده واحنا داخلين. خلاص اوكي خليه سمع.
ماشي.
ما اعرفش خش تاني
Yes, Dr. Amr Abul-Magd.
The follow-up of this patient, which is necessary, it's similar, like after a normal hysterectomy injection, it's different.
So this is Monica who you're talking?
Yes.
Yes, hi Monica, how are you? Yeah, please can you repeat your question?
These patients with viruses, if it's the same follow-up as after injection directly to viruses, or there's no need on follow-up, because
Dr. Nada, do you see me?
Yes, Dr. Amr, and we just received a question from Monica, and she's asking you regarding the follow-up after this injection.
Answer, I want to show you, this is the isolated fundal varix, is completely no color flow.
Yes.
Do you see it?
Yes, it's clear.
Just injected the inflow, one ampoule cyanoacrylate, completely obliterated this isolated fundal varix. Do you see?
Very elegant.
And very important issue now, and in the future we can management that patient with recurrent hepatic encephalopathy by this complete occlusion of portosystemic circulation by targeting this inflow, complete obliteration, portosystemic circulation, cutting the pathway at all, and it will be nearly future. And EUS is always rising towarding the endohepatology.
Fantastic, Dr. Amr. Thank you so much. But we received a question from Monica again regarding the follow-up protocol that you are doing for these cases.
I follow up this patient after 6 weeks by regular endoscopic evaluation of this isolated fundal varix after 6 weeks.
6 weeks. Okay.
Dr. Ibrahim, do you see me?
Yes, it's very good, and I think it's very good demonstrations, and I think the follow-up 6 weeks is good, and at that time you broke the vein. If the vein becomes solid, this means that it's completely occluded, which is very good, and it needs a good hand. Thank you, Amr, for that, and thank you, Nada, to give us a chance to return back to Amr, and then you can continue in your procedures.
Thank you, dear Professor. Again, Ibrahim Mustafa, it's a great honor to be with you in this